Welcome to AETCM, the emergency medicine channel. Today I'll be presenting a case of a 39-year-old patient who presented with alleged history of snake bite at around 45 minutes before presentation to ER. Patient had complaints of the right heel pain, and on initial 10-second assessment, patient was conscious and oriented.
When was the bite?
Around 45 minutes before the presentation. Evening, 7
To the heel area.
To heel, right heel. And patient on initial 10-second assessment, patient was conscious and oriented, and airway was patent. There were no secretions, and breathing wise, the air entry is bilaterally equal, respiratory rate of 22 breaths per minute, and saturation of 100% on room air. Single breath count at that point of time was 36. Circulation wise, BP of 120/80 millimeters of mercury, pulse rate of 96 per minute, and capillary refilling time of 2 seconds. Disability wise, GCS was E4, V5, M6, fully conscious oriented, and pupils were 2.5 millimeter equal and bilaterally equal, reacting to light, and she was moving all 4 limbs. And exposure wise, temperature was 97 degree Fahrenheit, and GRBs was 94 mg per deciliter. And we had done adjunctive primary survey.
Okay.
ECG.
So in the primary survey, what will you anticipate in a snake bite patient?
In snake bite, initially airway wise, we'll have to see for any secretions, pooling of secretions, or any like allergic reaction to the envenomation. If there is any allergic reaction, there can be angioedema, and airway obstruction can occur. And other one is the in breathing wise, we'll have the diaphragmatic muscle paralysis or the intercostal muscle paralysis if it's a neurotoxic envenomation. And in that cases, we'll have to intubate and mechanically ventilate
So we
the
need
patient.
to look for any features of neurotoxicity, any bradypnea or anything. Okay.
And also single breath count monitoring.
How will you ask for single breath count?
Single breath count, we'll ask the patient to normally inhale and exhale, and count from 1 to maximum how much he can count. So that number will be noting down, and then we'll serially monitor the single breath counts, and if it is reducing, then we can suspect there is a worsening of inspiratory effort.
Okay.
Because ABG also in this patients, we can't take and monitor the PCO2 retention because of the bleeding manifestations they can land.
Okay.
And circulation wise, we'll have patient can have hypotension, shock, bleeding manifestations, tachycardia. All responses will be there.
Okay. When all a snake bite patient will have tachycardia, if there is any cardiotoxic features, hypotension.
Hypertension, it can be due to the cardiotoxicity, then it can be due to the hypovolemia, bleeding, leading to hypovolemia. It can be due to the anaphylaxis to the venom. Anaphylactic shock can be present, and it can also be due to the if there is any adrenal or pituitary involvement, insufficiencies can.
That is in later stages.
Later stages
After many days, patient might have sepsis and septic shock related hypertension might be there, or patient might be having any adrenal insufficiency pituitary. But even without envenomation, patient might have hypertension. Patient, because of the fear, patient might go into vasovagal shock, syncope like that. Okay.
Then disability wise, we'll have to see for any reduced sensorium, which can again imply the hypotension.
Why is patient with snake bite having reduced sensorium?
Reduced sensorium either due to the hypotension causing the decreased cerebral perfusion, or the IC, any intracranial hemorrhages can occur. That can also lead to reduced sensorium. Then
the venom itself. Venom itself will contain phospholipase A2 and all. This itself will hinder the sensorium. So that will patient might be drowsy because of the venom itself. Okay.
Then pupils wise, if the nerve involvement is there, initially the sphincter pupillae and all can get affected. That some dilatation we'll be able to see. Okay. Then otherwise we'll have to see for any neurological manifestations like ptosis, initially present with ptosis, or any facial bulbar palsies. Anything we have to see any obvious bulbar palsies, and also for any weakness, obvious weakness we have to see.
Okay.
Then
so this patient primary survey is normal.
Normal.
Okay. Adjuncts, what
and
do you do?
adjuncts of primary survey, we'll have to take an ECG, and that
First
here.
step, what will you do? First step in a
first we will immobilize the right lower limb. We had immobilized. If it was initially in the in a local hospital without any further facilities for transferring and all, we can actually apply crab bandage, elastic crab bandage. We can apply.
How will you apply?
Apply if in this case it's a heel bite, so we'll apply from the foot itself. We'll roll in such a way that there is not like excessive compression on the limb. It should at least allow for the superficial circulation. The deep circulation should be patent. Like the arterial flow, everything should be patent. Only the superficial lymphatics should be obstructed, so that it should not be over tight or it should not be loose also. So that midway you'll have to keep it, and also we have to splint the limb. We can use a splint, and the joints at the bite site can be immobilized and wrapped with the crab bandage itself.
Okay. So how will you apply tourniquet in a snake bite patient?
Tourniquet ideally we should not apply because it can compromise the deep circulation, and patient can have peripheral gangrene. And also ideally we should not apply that. Other ways we can measure the BP of the lower limb, and 20 millimeters of mercury above we can keep.
Okay. So whenever you are applying tourniquet, we should allow at least 1 to 2 finger space between that, so that the arterial flow will not be cut out. Okay. Suppose a patient came with a very tight tourniquet on the limb. How will you release it?
So in that case, we will have to tie the BP cuff above the tourniquet, and we should with the BP 20 millimeter above, we can keep the cuff pumped, and then we can remove slowly the tourniquet.
Tourniquet. Why
and then
should
we can
do that?
because it will avoid the rapid release of the venom and toxins into the circulation. The patient can rapidly deteriorate. So that prevention, we can put the cuff and then slowly reduce the BP, the pressures, and release it.
Okay. So we have talked about first step immobilization.
Immobilization.
Then also mark the site of bite. So we need to look for any local
swelling, and if there is any increase in swelling, we'll have to see any blood formations, any other inflammatory responses like redness, pain, severe pain, disproportionate pains, and if the patient has swelling and all, we have to see if the patient is going into any compartment syndrome. And also we'll have to examine the lymphadenopathy.
That is an examination. So first step we will immobilize the patient, then we will mark the wound,
site.
Then samples, what will you take?
Samples initially we'll start with the 20-minute whole blood clotting time, and by that time itself we'll send the blood for PT INR.
So most important test is PT INR, because it will have some delay. Because of that we are doing the WBCT. Okay, what is WBCT?
WBCT is whole blood clotting time. We'll take 1 to 2 ml of blood in a clean glass container.
2 ml of blood.
2 ml of blood in a clean glass container, and keep it undisturbed for 20 minutes. Usually it clots in 6 to 8 minutes, but if it is getting prolonged more than 20 minutes, we'll have to arrange for ASV and again repeat the WBCT. If again that is positive, we can.
Okay. When will you repeat the WBCT? Suppose when will WBCT be positive? Like when will the WBCT?
When only all the coagulation factors are involved in severe envenomation, only you will get WBCT positive. So INR is more sensitive. If just 10% decrease from the baseline itself, then INR will show worsen.
Okay, so in all cases WBCT might not be positive. Probably. So when will you repeat WBCT? So if there is a delay of 2 hours for getting the INR report, we will have to repeat every half hourly. So once you do a WBCT, after 20 minutes we will be able to know, then wait for 10 minutes, then again next sample should be taken. So till we get an INR report, you need to repeat the WBCT. Okay. And in the lab, what all things will you send other than the INR?
INR, rest we have to send CBC to check for any HB hematocrit. Anything, because any hemolysis is there, then the HB hematocrits will be low, and also the hematocrit can increase if there is any capillary permeability was increase is there. Then other things, RFT we have to send to see for any acute kidney damage or any rhabdomyolysis causing the
for rhabdomyolysis you need to send
also send
CK.
Total CKs and urine myoglobin we can send. URE examinations will get that any hemoglobin is there or any myoglobin is there, and then peripheral smear we can send to see for any schistocytes, any fragmented RBCs, and then we can
Then other coagulation factors, APTT,
platelet fibrinogen has to be sent. If INR is increased, that also has to be sent to see for any DIC.
And if we are suspecting renal failure, also send for the potassium levels.
And in rhabdomyolysis also, the potassium levels will increase. Hyperkalemia will be present.
Okay. So we have done immobilization, basic blood test we have done, and we should assign one person to check for the single breath count. Okay, sample history.
And then sample history wise, 13-year-old female patient who's with no known comorbidities. She was walking near the railway cross side road, and at that time a snake had come and bit her right heel. She didn't notice any pattern of the snake, and she came to ER with complaints of right leg pain only. There are no any other swelling, local site swelling from the history or any vomiting, breathlessness, any diplopia, slurring of speech, no history of any weakness or any bleeding manifestations, giddiness, any syncopal episodes. And then
so what are the envenomation features? What all things will you look or ask her?
We have to ask for any local site changes initially, any swelling, any disproportionate pains, or any blebs like that a patient has noticed or not. Then any upper groin, if it is lower limb, then we'll have to ask for any upper groin, any pain is there, for any tender lymphadenopathy like that changes is there, they'll have pain over the lymph node site. And then we can ask for the systemic envenomation features. So in that it can be either neurotoxic, hemotoxic, or any nephrotoxic, like that it can be.
Or in seismic
myotoxic also. So neurotoxic, as we have discussed now, we have to ask for any diplopia changes, ophthalmoplegia changes, or any ptosis.
So first change will be diplopia. Patient won't be able to appreciate the ptosis and ophthalmoplegia. So first we need to ask for any double vision.
Then ptosis patient, otherwise they can also see. Then after that we have to ask for any weakness, any slurring of speech, like facial palsy symptoms. We'll have to ask angle of mouth deviation. Then we'll have to neck muscle weakness. Then any breathing, difficulty in breathing. We have to ask for any intercostal muscle or respiratory muscle paralysis. Then further is the hemotoxic manifestation. We have to ask for any gum bleeding, any local site bleeding, then any abdominal pain, or any vomiting, hematemesis, like that. Any bleeding manifestation as such we have to ask.
Sometimes diarrhea can also be there.
Then after that we will have to ask for the myotoxic, which is the muscle pain, disproportionate muscle pain.
Cardiotoxicity might not have much manifestation. They might be having palpitations,
arrhythmias, syncopal episodes. Then nephrotoxic, reduced urine output, that we can ask.
Reduced urine output or
any dark colored urine.
Myotoxic,
any muscle pain, cramps will be present.
And dark colored urine. Okay. So these are the symptoms which you need to ask the patient if the patient presents with a snake bite. Okay.
Then no other allergic history or any past history of any illness, not on any medications. Last meal intake was by 4 p.m., 3 hours before. And then patient on examination wise, she was conscious oriented, moderately built and nourished, and there was no pallor, icterus, cyanosis, clubbing or lymphadenopathy. The chest was, air entry was bilateral equal, no added sounds. Then CVS wise also S1, S2 was normal, and GAT wise, abdomen wise it was soft, non-tender. CNS wise, GCS was E4, V5, M6, pupil sequel and reacting light, no facial palsy or any other cranial nerve palsy is noted, and no the extraocular movements were normal, and also the power, all 4 limbs were 5/5, and no cerebellar signs were present. And further we had also checked for any postural hypotension features also, but the supine and standing BP was supine was 120/80 and standing was 120/82. So okay. And then local site examination, the right heel, there are 2 marks, marks were there, fang marks we are suspecting, and also there are no any local site edema, and also the lymphadenopathy was also checked. There was no any tender lymphadenopathy.
Okay.
Going to reach.
So history-wise, there is a snake bite, but we got a clinically stable patient at present.
Yes.
Okay. So sometimes the patient, usually so patients are like that. They will be coming and asking whether, sometimes they might have a doubt whether snake itself bit or not. So they will be asking whether it is a snake bite, whether am I envenomated or not. In that case, how will you answer them?
First, we will have to tell even if there is a bite mark or not, we have to observe them for minimum 24 to 48 hours, and it's based on the symptoms that we will be other further management will be based on the clinical features the patient presents it, and not just on the bite. If the patient has any suspicion, we'll have to admit and observe for at least 1 to 2 days.
Okay, so what all are the big fives?
The big fives in common in India is Cobra. Then we have the Elapidae group, which is Cobra and common crate.
Common Cobra and Cobra.
Common crate. And we have Viperidae family, which includes the Russell's viper, saw-scale viper, hum-nosed pit viper. Then other is the Hydropteridae, which is the sea snakes. And then Crotalidae, so also that is pit viper.
Okay.
And big fives are mainly the Cobra, common crate, Russell's viper, saw-scale viper, and hum-nosed pit viper. These are the big fives. And in this Elapidae group is mainly neurotoxic, which is the common Cobra and common crate. And the Viperidae group is mainly hemotoxic, coagulopathies with the hemotoxic 3 vipers.
So what is the difference in mechanism of the venom of Cobra and crate?
Cobra, mainly it is action is on the postsynaptic ACH receptors. It blocks the postsynaptic ACH receptors, and it is more reversible. But whereas in common crate it is presynaptic receptors is what the toxin goes and blocks. It's the Bangara toxin. So that goes and blocks the presynaptic receptors and is more irreversible. So as time passes, the more delay in treatment, the more irreversible it will be, and more clinical manifestations the patients will be having.
So in crate patients, if there is any manifestation, we will have to give, along with ASV, we might have to give other agents like atropine or stigmine. These agents also might be considered.
But since it is irreversible, it is less likely to act on this patient. More in Cobra bite, it is more potent for action.
Then what is the mechanism of action in this one? Hemotoxic envenomation. They will be releasing the proteins like the hyaluronidase, these enzymes and proteins will be released, and some zinc metalloprotease will be released, and that will destroy the endothelium of the patient and will cause vascular leak everywhere. Okay. So what are the syndromes when patients present to ER? What are the different syndromic approaches?
Based on syndrome itself, we can actually see which kind of bite the patient might be having based on the presentation. So the first one syndrome the patient can present it is the local site edema with bleeding manifestation. So in that we will have to suspect viper family. Viper family we can only suspect. But if the patient has additional features such as any renal failure with the hemotoxic feature, then we'll have to suspect hum-nosed pit viper. But if again patient has also neurological manifestations also, that is almost all systems are involved, then we'll have to suspect Russell's viper.
That is syndrome
most commonly 2. That is syndrome 2. And syndrome 3, we'll have to see if the patient has local site manifestation with neurological features of thalanoplasia, weakness and ptosis, then we'll have to suspect the Cobra, common Cobra bite. To differentiate it from the other one, which is the common crate. The common crate usually bites at night time, and it actually the patient won't notice the bite usual times, and also the mark also won't be seen usually. So in that case itself, we can, even if patient asks regarding, if the patient has doubt regarding any bite with fang marks itself, we can't say if there is any suspected bite also. So they won't have any bite mark, and they might not notice any crate bite also. And they have other similar features of Cobra itself. with the neurological and local site. Local site will be less also. Local site inflammation and will be less. Only mainly the neurological manifestations will be the main presentation, and also there can be rhabdomyolysis features in some grades. And then the fifth one is that is 3 and 4, and fifth one is the mainly the renal involvement. The patient can have the urine color difference, the dark urine will be present, and reduced urine output with the local site involvement, and may have also contact with water history. So that time we will have to suspect sea snakes can be presented in such a way. And also
fifth one is dark urine, Russell's viper. Dark urine with paralysis with renal failure and bleeding manifestation, Russell's viper.
All systems and Russell's viper.
Okay. Then, this patient, so what are the abnormalities you detected in this patient?
In this patient, we had monitored PT INR every 6th hourly, and local site examination and lymphadenopathy.
Why every 6th hourly you are monitoring INR?
Only
new coagulation factors will be formed. It will take 6 hours to form that. So, initially, if you are sending and if you are getting a normal INR, we need to repeat after 6 hours. Okay.
We had monitored also the SBC counts, and in this patient INR initially was 1.1 and platelets was 2.41, it was normal, and HB was 11 with the and after that we had monitored it was serially rising. INR was initially 1.1.
SBC remained stable.
SBC was stable itself. Patient had no complaints of breathlessness.
And local site also?
Local site also not much inflammatory response changes were there.
Okay.
Except that she was having pain over that site. And after that serial INRs we monitored, it was showing rising trend. Initially it was 1.1, then after 6 hours it was 1.3, next 6 hours it was 1.5. So it was serially rising. We had
so what is the INR cutoff value we take for?
1.2 is the INR cutoff value.
So if we get a value of 1.3, immediately you need to repeat, because anyway it is more than 1.2. Immediately you need to repeat to confirm. Sometimes it can be a lab error. So repeat immediately and see. Okay.
And then
so you got a value of 1.5
without any systemic envenomation features. So we had arranged, since the INR was worsening, it is an indication for giving ASV, and we had arranged for the anti-snake venom, and also we had arranged for at the same time the adrenaline. 1:1000
so suppose
adrenaline.
INR was normal, and what other lab parameters will you check?
INR was normal, we'll have to check for the HB, hematocrit, platelet count. Then
so below what value of platelet will you give ASV?
Below 1 lakh.
1 lakh. In a patient who doesn't have any previous reasons for any thrombocytopenia or any APTT or
fibrinogen less than 100 is also another cutoff.
But isolated fibrinogen will not be there. Low fibrinogen won't be there. So any APTT value or PT value more than 3 or 4 times should be also considered. Not only INR.
4 seconds more
should be considered.
PT.
Okay.
And then we had arranged for ASV. At the same time we had arranged for adrenaline also. And we had given initially 10
vials. So this patient's criteria is met. For giving ASV. So before planning on giving ASV, you need to, what should you do? You need to inform the patient and the bystanders. And you need to get an informed consent for giving ASV. Why is that important?
Because it is equine formulation, and patient will have higher chance for anaphylaxis and shock and cardiac arrest.
Why this patient is having? Why patients might have anaphylaxis to ASV?
Because it is a equine formulation.
It is made from horse. So sometimes they might have allergy or anaphylaxis. Okay.
And we'll also have to ask if the patient has any previous history of any allergic reactions. If the patient is prone for any allergic reaction or previous history of any anaphylaxis, we can give a prophylaxis dose of adrenaline before the ASV.
So anaphylaxis to what? Sometimes patients might have anaphylaxis to anti-rabies vaccine or anaphylaxis to TT. In these patients are having higher risk of having anaphylaxis to ASV. In such patients, you can give prophylactic dose. What will you give?
We will give adrenaline half dose 0.25. We can give a sub-Q. IM we can't give because it can have a more chance of hematoma and all. So sub-Q dose we can give half
So
dose.
the absorption will be slow
Slower
and chance
absorption.
of tachycardia will be less.
Less.
Okay.
Side effects also will be less. And then we can give.
So only if this patient is having high chance of anaphylaxis, then only we will be giving. Otherwise, we will be avoiding. So sometimes someone might ask you, why can't we give any chlorpheniramine malate or hydrocortisone before giving ASV? Is there any point in giving?
In studies conducted, it has not proven no efficacy with the antihistamines and steroids, and also giving steroids along with adrenaline has shown to cause decreased efficacy of adrenaline. So that also should be avoided.
So why antihistamine shouldn't be given?
Because no efficacy,
Because here the anaphylaxis is not because of the IgE mediated, it is complement mediated. So only adrenaline works. So there is no point in giving all those. Okay.
And then for this, ideally we can start with 10 vials of anti-snake venom. So each one vial we will have to mix with 10 ml of saline, 0.9% saline or
saline or sterile water will be given along with that. So either it can be ASV can be in a liquid form or in a powdered form. So if it is in a powdered form, it will be it will last for 5 to 6 years, and that can be stored in room temperature. If it is liquid form, that should be stored in refrigerator. So if it is in a powdered form, it will contain the diluent with it. So mix. How will you mix it?
We'll take the 10 ml of this sterile water and we'll add it to the ampule, and we will
swirl it. Don't shake it.
Shake it. Just swirl it, and then we'll take again like that 10 vials we'll take. So total it will be 100 ml. So we can give as two methods. One we can give as bolus method or infusion method. In bolus method, the person who's giving will be present there continuously, and he will be giving around maximum 2 ml per minute can be given, and she'll at the same time he or she will be observing for any signs of anaphylaxis also can be observed. That is the plus point of that giving us a.
So if we are giving 10 vials, then it will
over almost 1 hour, 1 to 1.5 hours.
It will finish within 50 minutes if you are giving 2 ml per minute.
2 ml per minute. Then if it is giving as infusion, we can mix it in 250 ml of D5 water or NS and give as an infusion over 1 minute, over 1 hour. But sometimes people, if we don't notice, we'll put it at a higher infusion or a higher rate of infusion, then the patient can go into anaphylaxis. So that is.
So will you give test dose before giving ASV?
Test dose also not required because it is not IgE mediated, it is complement mediated.
Okay.
So already if we give also, the patient will develop some reactions, local reactions will be developed.
And which method will you prefer, push method or infusion method?
Push method is the better method. We can observe for any anaphylaxis.
So one person will be near the patient and will be giving this push doses. If they are giving, then we will be able to observe the patient. So push method is more preferred. Okay. Then other than anaphylaxis, what are the other side effects that can happen? There can be this pyrogenic effect because it is from the horse. So because of that, there can be fever, rest of this thing, and late onset serum sickness can also be there. Okay. So after giving ASV, when will you decide whether to give another 10 vials or whether to stop this ASV? What
we'll have to see for any further. If the patient had any symptoms, we should see for any improvement in symptoms. If there is
when all the symptom improvement will happen?
Around 30 minutes to 1 hour, we will be able to see symptom improvement.
So if there is any local bleeding, it is supposed to stop within half an hour.
Stop immediately, half an hour.
Half an hour. Then any neurotoxic envenomation, that also should stop within 30 minutes.
30 minutes. And then any hypotension is there, that will be corrected within around 30 minutes itself.
So when can you, so this patient's INR was 5. So when this patient didn't have any other manifestation. So in this patient, when will you repeat?
In this patient again, if there is no local signs or any symptoms, we can repeat after 6 hours.
So even whatever symptom, if the patient doesn't have any systemic manifestation, then you can repeat after 6 hours. So blood test can be done only after 6 hours because the coagulation factors will take at least 6 hours to form. Other patients, if there is any ongoing bleeding or ongoing manifestation, you can
you
give
can give another 10 vials.
10 vials of ASV. Okay.
Usually, if there is 1 ml of this thing can neutralize 0.6 of Russell's Viper and Cobra, whereas other one, the crate and saw scale Viper usually neutralizes 0.45 mg, 1 ml of
Which snake doesn't have ASV?
No spit Viper doesn't have ASV. These people mostly will have renal dysfunctions, might require renal replacement. Prolonged dialysis will be required.
Okay.
Then other adjunctive treatments we can give in Cobra envenomation and all. We can give atropine with neostigmine. Atropine 0.6 mg IV and neostigmine 1.5 to 2 mg IM can be given. And we can repeat every 5 to 10 minutes. We can repeat the dose of 0.5 mg until we get response. Then other supportive methods of if there is any hypotension or shock, we'll have to give 30 ml per kg of IV fluid crystalloids and arrange for blood for transfusion.
So if this patient is having if this patient's INR was only 1.5, sometimes patient's value might come INR and APTT as no clot detected, NCD. If we are getting such values, then in that scenario you can give other agents.
Plasmas we can give 15 ml per kg, and if there is any DIC, the patient is going into any DIC, then we'll have to give cryoprecipitates also. Dose around we can give 1 to 2 bags per 10 kg weight. So for every 2 to 3 units of FFP, we can give around 5 to 10 units of
cryoprecipitate. Okay.
And then other supportive vasopressors support and all we can give. The hypertension is not improving.
Okay.
Further, then dialysis, supportive dialysis, and then securing the airway if the patient is in respiratory paralysis, intubation and mechanical ventilation.
Okay. What happened to this patient then?
This patient, after that, the serial INR we mounted every 6 hours. Patient didn't have any systemic or local envenomation features, and INR progressively decreased after the initial 10 vials itself, 1.3 and then 1.2, 1.1, and we discharged the patient.
Okay. Okay. So suppose you get a patient with Cobra spit ophthalmia. What is that?
Cobra spit ophthalmia patient will be having conjunctival congestion features, whitish sediment.
Do we have to give ASV in a patient who is coming with the Cobra spit?
No, washing and supportive management of endophthalmitis.
So usually this Cobra, it is actually a defense of Cobra to it will aim at the patient's eyes and spit the venom into the eyes, so that the patient will be having a temporary blindness, severe ciliary spasm, watering and irritation, pain will be there, and so that the patient won't be able to attack the Cobra. So, and patient might have some corneal ulcers and irritation. So only analgesics and eye wash is required, and you can give any, if there is any ulcer or anything, we can give antibiotics. Atropine and all, and the vision will improve after some time if there is no major ulceration or anything. Yeah. This patient, what happened? Improved.
And we discharged.
Okay. Anything else?